Welcome to We Are Old, Get Over It, the podcast where we celebrate the wisdom of age and maybe a little grumbling too. This is exactly what happens on all my podcasts. We start laughing and everyone says, well, what's going on there? We're not telling you. We're not telling you. All right. Welcome back to the podcast. Today I'm going to have a very interesting discussion with someone who is known locally as the Pickleball Doctor. But basically, he's into pain management, and he's a physician. His name is Dr. Greg Rubin. I knew I shouldn't have had that cannabis drink before I started with you. Okay. Okay. So we're going to start a discussion, and I'm going to let him lead it. And if you would be kind enough, Doc, to just give us some background on what you do and how you do it, and then we'll just go from there, okay?
Perfect. Well, thanks for having me.
My pleasure.
So my background is I did my initial training in internal medicine at the University of Connecticut. And then while there, my mentor was the team president for the women's basketball team. And as we know, UConn basketball synonymous with winning championships. So, while I'm working on the hospital wards, I got a chance to work with him at the sideline of basketball games. And I'm like, wow, this is something that I should be doing. So that led me to do a sports medicine fellowship, which is an extra year training in sports medicine at the University of Kentucky. So, another big, athletic program, getting to take care of all their athletes, football, basketball. And then that led me to Naples, where I've been working for the last 7 years, doing primarily non-operative orthopedics. So that involves the treatment of acute injuries all the way through, the management of chronic illness and joint pain. So kind of full spectrum non-operative orthopedics.
Okay. And your practice or your experience at the universities is a lot different than your experience here in Naples, Florida. Isn't that correct?
Yeah, so I mean, you're thinking about different patient populations here. So we do take care of our young athletes, primarily a lot of high school football players, basketball. But yeah, the majority of our patients are going to be either our active retirees, our weekend warriors, and they're going to be doing things like golf, tennis, pickleball. Those are going to be our primary sports of interest.
Okay. So let's talk about seniors in particular, because that's the audience that usually listens to my podcasts. Uh, what kind of injuries do seniors have in particular in sports?
Yeah, so, I think they're going to be categorized in a couple different ways. So primarily, we're going to see a lot of acute on chronic injuries, meaning some pre-existing condition, whether there's some baseline arthritis, meaning a little wear and tear in a joint, or an exacerbation of, a tendon issue where maybe we had a little wear and tear of the shoulder and then reached for a ball and developed an acute exacerbation of pain. So a lot of times, we'll get these aches and pains and patients will be like, yeah, my knee would ache and it would go away on its own, but this is worse. This is the worst it's ever been. That's what we mean by, there was probably something chronic going on, but now there's an acute exacerbation. Now, there are some patients we are seeing purely for their first injury. Maybe they developed an acute meniscus tear, an acute ligamentous injury, but, primarily I'd say the large majority is there was some wear and tear in the background that was brought to the surface from one of our activities.
What are the unique challenges for seniors as far as their physical activities as they age?
So the biggest challenges we're going to have are, exactly what I just almost alluded to with there's pre-existing conditions there. So, we're going to be trying to maintain our level of fitness that maybe we were at 20 years ago. We're going to be even more active now because maybe we've retired and we play sports 7 days a week. So we're putting a lot more, strain and stress on the joints, and they don't have the reserve that they used to. We've lost some of our muscle mass. We haven't been active for the last 20 years, and now we're pushing these tendons that maybe had a little bit of fraying to begin with, and stressing them a lot more than we used to. So I think the challenges are how do we match expectations sometimes with what the reality of the situation we're dealing with.
A lot of this has to do with pain management, correct?
Well, I think that's part of the process. It's going to be, to focus on the source of the pain and then also focus on all the compensatory, you know, changes that will occur in our body around it. So, for example, with someone who presents with knee arthritis and has knee pain, yes, we want to help treat your pain, but it's also leading to, ligament instability around the joint. It's leading to atrophy our quadricep muscle, which may put strain on the opposite hip. So it's really a kinetic chain. It's, not just isolated pain. It's related to a kind of systemic inflammation in that area. So there's a lot of, I think, components that go into treating the pain at the end of the day, but I think it's more than just pain. It's function, it's,
Is
strengthening.
there I'm sorry for interrupting. Is
Oh
there
gosh,
a
no.
fear of pain medication? Is there something about addiction that people are concerned about, do you think,
Yeah, I think
after
that's what
you've done your
drives,
diagnosis?
yeah, that drives most of my practice, guidelines because, you know, as an internist, that background, I always love to avoid the systemic anti-inflammatory. So that would mean, taking Advil, Aleve, Motrin every single day. I mean, that's been shown to have long-term cardiac side effects, renal, kidney side effects, high blood pressure, GI upset. So, to be able to offer treatments that go beyond relying on oral medications for NSAIDs is huge. Then, as far as treating acute pain with opiate level medication, yeah, it's habit forming. Two, the efficacy isn't that great for what we're treating from an orthopedic standpoint. And side effects from that standpoint too, constipation, respiratory depression. I mean, there's a lot of side effects that we can avoid if it's something we could treat with either a rehab or an injection standpoint.
About acute diagnosis, explain that to me and what that means.
Yeah, so a lot of times patients will present to us, for, hey, I developed pain within the last 48, 24 to 48 hours. And typically what we'll need to do is, one, we'll take an x-ray, right? The x-ray, even though if we even think it's soft tissue, we want to rule out that there's any structural abnormality within the joint space that we can't appreciate on exam that may be, contributed to the pain that we're feeling. And two, it's doing an evaluation. We follow a mnemonic where we inspect it, we palpate it, we assess range of motion, we assess the muscle strength, and then we do special tests. So it's kind of a systematic approach of evaluation of a joint that leads us to a differential of this acute, exacerbation. And then, with that differential, we look at our X-ray, exam findings, and try to come up with a safe treatment algorithm, treatment solution.
And uh, the non-pharmaceutical approaches are what?
So I like to stay conservative to start with. So, the first, depending on the etiology of their pain, but say it's a strain or a sprain, physical therapy can play a role in strengthening the surrounding musculature to help maybe take the pressure off of an inflamed joint. They can do soft tissue modalities with ultrasound and electrical stimulation to help with the muscle spasm in that area. If those things fail or the pain is just to the point where we need to take more aggressive means, that's when we can start getting into things like injection options. And injection options can really be, full scale from, corticosteroid, which is an acute anti-inflammatory injection, to, what we're getting into more now, more biologic treatment. You may be using the body's own blood supply or your own bone marrow to help with actually healing these areas.
Should the individual, when they start taking on a sport, like let's say, for example, someone like myself who used to play tennis, hasn't played tennis for 20 years, and all of a
Yeah,
sudden I meet you and you say, well, you want to play pickleball with me?
yeah.
What lifestyle modification should I be making in anticipation of playing not as necessarily a competitive sport, but a sport that is becomes competitive and is a social sport?
Yeah, I mean that's the biggest challenge with pickleball and why I think we see so many injuries is it has a very low barrier to entry. It's not a I need to be conditioned like you would in tennis, before playing. You don't need, a significant of strength, but you can just pick up a paddle and, go out and play. But if someone hasn't played for the last 20 years, it just primes those, acute on chronic injuries, those tendinopathies to become inflamed, the knee arthritis that maybe was laying in the background, but there's some wear and tear in that area now. And also even things like balance. Our balance is affected as we're getting older, and we can increase our risk of falls if we're not, building up those core muscles before we get out. So I wish there was a foolproof plan of, hey, if you do X, Y, Z, you're going to be safe on a pickleball court. But I think, like anything, moderation is going to be key. You're going to have to ease yourself into it and then find that level of play that doesn't tip you over, because we're all going to have different thresholds. Someone's going to be able to play 5 days a week. I may be only able to play 2 days a week, but at least when I get out there, I can go out and go full go. But 5 days a week, I'm going to be in the doctor's office.
I so you would suggest that they do a warm up procedure no matter what. They they stretch in
Yeah,
different
so
ways, and I'm sure that if you
stretching is
go,
fine.
yeah,
Stretching is going to improve your elasticity, help with your neuromuscular feedback, which are all good for the long term. But the most important is what you said first is more of an active warm up. We're going out to play. The stretching is important, but it's more of, don't go cold right out onto the court. We need to get that heart rate going, get flow to the muscle groups to warm up. And that has much more evidence than maybe just an aggressive stretch program before you go out there.
what is the what is the most common injury that you're treating related to pickleball, for example?
All right, I'll give you a top three because I think that's an easy one. So if we start at the upper extremity, we're going to see a lot of what we call rotator cuff impingement. So with pickleball, we're talking about a lot of reaching overhead hits, and that's going to put pressure and basically pinch the rotator cuff. So when the rotator cuff gets upset, maybe because repetitively it's getting irritated, or maybe there's a small little partial tear or fraying, it causes bursitis, which is inflammation that wraps around the muscle layers of the rotator cuff and causes pain at time, wakes you up from sleep, really limits your reaching ability. So I'd say that would be in the top three. Second would be tennis elbow. So tennis elbow is pain right on the outer portion of the elbow. Repetitive. Again, that area is really poor blood supply. So when we strain it and stress it repetitively, pain is really hard to get away, to go away. And then finally, third, an exacerbation of knee arthritis is very, very common, meaning, there's some wear in the meniscus, our stabilizing structures, a little thinning of our cartilage. We go out, we twist, we bend, and basically those inflammatory cells come to the knee, cause swelling, pain. Um, and that's usually when we get you back in here.
And how do you treat all three of those items if someone comes into your, because
So,
you do non-surgical, correct?
yeah, and most of these, we'll be able to get fairly good progress with non-surgical treatment. I mean, at the end of everything, yes, full thickness rotator cuff tears are going to potentially require surgery. Bone on bone knee arthritis may require an arthroplasty or replacement. But, first line measures, whether it's just first, hey, how many days a week were you playing? Well, I was on a trip and I played 5 days a week. Right, well, maybe we need to cut back on that first, so making those lifestyle modifications, easy change to make first. Then we're going to go into, well, what have you been doing to, strengthen the core muscles? What are you doing to work on the rotator cuff and the scapular stabilizers? So we'll take that rehab approach next. And then depending on the level of acuity, that's when do we need to put a steroid in to decrease the acute inflammation? Or do we need to say this is more of a chronic tendonitis or a chronic arthritis picture and focus more on the biologics, PRP, what we call bone marrow aspirate, things like that stem cell category to help try to, make lasting improvements with, a procedure or an injection.
How would you recommend people exercise or warm up to present to stop the falls that they have? Because I would think that that's also a major item, correct?
Yeah, those are probably the bigger injuries you're going to get at, pickleball, the head injuries from a fall. We see a lot of radius or distal radius, so wrist fractures. So I think that's more than just a warm up. I think that's a lifestyle change. And I think that starts with, walking every day. I think it starts with getting into the gym and strengthening the core muscles, the gluteus muscles. Um, it's getting a trainer and working on the half moon shaped ball and working on your balance. It's all of those kind of all those modalities.
Okay. And what other suggestions would you have for people who are just starting out? They've just retired and they say, geez, all of our friends are playing pickleball and it's a very social sport. What would you suggest for them to try out?
Yeah, so I think, the good news is, like we said, you're going to be able to get out there, but I think it's getting out there in a timely fashion, meaning, you know, same kind of algorithm. Make sure that you can go for a walk for 20 minutes around the block without developing knee pain first. Make sure that you can, go to the gym and complete an upper body workout without waking up the following morning with severe shoulder pain. And then if you can do those things, that's when, do a practice session, see how you feel, kind of take your body through this kind of tough word, acclimatization. I'm butchering that word,
That's
but you
okay.
have to acclimate
I
your
butcher
body.
a lot of words.
Yeah, that one always gets me, and I try to avoid it with patients. um, but you have to ease into it, is a nice way of saying it. Take your time.
All right. So, any final thoughts about what you think you would like to get out there, since you are known in Naples at least as the pickleball doctor?
Yeah, so I think the important thing is, we can treat acute pain. That's not going to be our issue. We'll get things to settle down. I think the hardest thing that we see is, those repetitive injuries and setting the expectations that if there is a partial wear and tear, rotator cuff tear, it's not going to regrow itself. A lot of this stuff, despite our best efforts of injections, therapies, we're not going to fix it. It's still going to be there. Now, it may be less prevalent than it was before, but it won't be back to normal. So it's really finding that middle ground. How many days a week can we play at a high level without tipping ourselves over, knowing that despite, care, we just may not ever get back to complete what we define as normal, for the patient. So
Have you ever had anyone retain you to be uh, their medical backup when they're as either a professional or semi-professional player?
So when we cover, previously I've worked for Florida Gulf Coast University, the Florida Everblades. So more of that relationship where we take care of the athletes for the university system.
Mhm.
We attend their games, a lot of sideline coverage, late nights in the training room. So again, that's treating different sort of injuries. Population, we're seeing much more of, the acute ligament injuries, the acute meniscus injuries, more of an acute than acute on chronic.
Mhm. Okay. Any final words you'd like to say?
Oh
I do have
gosh,
one
yeah. So
question though. I have one question
yeah,
afterwards. Let me ask my question first, and then you can answer me. So, if I come back to your practice,
yeah.
do I have to wait for half an hour to get to see you?
I like to think we're one of the faster offices around
I'm
town,
just teasing
but
you. I just wanted to see
yeah.
the reaction.
So, I think the things to think about now is, we kind of we briefly alluded to, kind of these general guidelines. I
Yes.
think in the field of non-operative ortho, this big push has been to kind of that orthobiologic standpoint. And that field is just, even though we've talked in the past about platelet-rich plasma and stem cells, it's really just becoming standardized. So I think a lot of the misconceptions are, hey, I saw a study or I read a paper that, PRP does nothing, or, stem cells aren't real. It's finding what are the as at least as a field, we're trying to standardize these things. We're trying to get to the point where if we do a platelet-rich plasma injection, which is a blood-based one where we take your blood and we spin it around and basically inject your platelets back in. Whereas we used to just take a varying amount of blood. Some studies said 5 cells or 5 cc's, some did 20. We're trying to standardize it and basically say, if you're going to do an injection for knee pain with PRP, you better have 10 million platelets. So we're using cell counters to make sure that there's actually some standardization with these approaches, because this blanket one size fits all, I had a PRP, I had stem cells, when you really get into the details with patients, what they had probably wasn't going to do anything anyways. So the big thing to be cautious about with non-operative care is make sure you're getting it from someone who's, up to date on the literature and is doing things with cell counts and protocols that are being basically established in real time almost.
Okay. Well, great. I think you covered most of the points and you did a good job.
Thank you.
Yeah. What I want to ask you is, uh, can we put your business phone number and your website and so on up on our website so that people could find you if they would like to have
Of
you
course.
check them?
Yeah,
Also,
and I'll get the business phone number for you as quickly as I can, as soon as I get all that lease and everything kind of signed and tucked away.
no problem. I should just mention that Dr. Rubin was affiliated with uh, Naples Community Hospital, which is now a different name. What's it called now? Naples
Now it's
Comprehensive Health. They use the same
health, yes.
initials. I'm trying to learn it from the ads that they're running. Anyway, he had a very large practice there, but I think it's gotten so large that he decided to expand. So we're going to. He has a new logo, and I don't have his phone number yet, but I'll get it, and I'll put it up
Yep.
on the website. And I just want to thank you for taking your time and informing us on the problems that we have as we get older. Any last quotes? I have one.
I was glad you had one because I was racking my mind.
All right. I'll save you from that. I'll save you from that. I have actually two quotes I found regarding sports. The first one is every play, every practice, every moment, you've earned it. Now savor the victory of simply being here.
Hmm.
And the second one is your journey isn't defined by wins or losses, but by the spirit you brought to every competition.
Yeah,
And
I
then
mean,
the
at the end
third
of the
one
day, that's
is,
why we do sports, right?
and the
It's
third
to
one
enjoy
is get
ourselves,
yourself a good doctor.
right? Someone you need in a pinch. That's it. That's what we're here for.
Thanks again, Doc. And I
Oh,
thank
thank you for
you.
having me.
And I hope that everyone enjoys this podcast, which you can get the information on Spotify, on Apple Podcasts, and of course at our website, weareoldpodcast.com. And again, thanks, Dr. Rubin. We appreciate it.
Thank you.
And that concludes this episode of We Are Old, Get Over It. Thanks for joining me. I hope you found our conversation both insightful and entertaining. Remember, age is a journey, not a destination. So embrace the wrinkles, the forgetfulness, and the occasional tech frustrations with a good dose of get over it attitude. Until next time, keep laughing, keep learning, and keep getting over it. Ken out.